Welcome to Didactics, and as mentioned, everyone calls me D or Dr. D. I'm good with that for obvious reasons. My given name is Demetra Antimisiaris. I am a PharmD who has been recruited to U of L about 10 years ago to lead a special endowed program to study polypharmacy. I was recruited from Hawaii, and when people say, "What are you, nuts? You know, why would you come here?" Because it's not every day that a private citizen donates money to try to study the problem of polypharmacy. And previous to that, my background was I trained at UCLA, where we have a robust geriatrics program. It's interdisciplinary, and polypharmacy, being a traditional part of aging, has been my 26-year job, is to do medication management and consults on your 80-year-old who takes 26 meds. What do you do with that person? So it's been such a pleasure. It's been fun to work. I was in family medicine geriatrics. I'm now in Pharm Talks. And polypharmacy has become not just the domain of the elders. So back in my day, it really was just the old people who lived with chronic disease. But nowadays, as you know very well, it's young people, and increasingly even children are living with polypharmacy. So I really appreciate your interest or comments or anything you want to share while we're talking about this. First, we're going to talk about polypharmacy just as like a primer and a background about how to think about it, how to approach it. And then the next talk, we'll take a break, is on managing polypharmacy in the 15-minute office visit. As if that were possible. It is, trust me. So here's your objectives. I'll let you peruse through that at your convenience. And so I'd like to start off with just defining polypharmacy. The medical literature defines it as 5 or more medications taken simultaneously. And when you're my age, you have friends all over the world, and I got an email today saying in Great Britain now 53% of all the people over 65 are taking 5 or more medications. So it's not just our country. That said, polypharmacy is a side effect of wealthy nations. In Great Britain, the average script per capita was 16 the last time I took a look, and we're going to talk here in a minute about what it is in the United States. You're going to be surprised. But in Pakistan, it's 3. So it really kind of depends on, can you afford these medicines? Can your health care system afford to give you access? And some people have various other definitions. My favorite is more medications than are clinically warranted. Yes?
My only question about the Pakistan statistic is, were those less medications than were warranted for that?
Yeah.
You can't control, but in terms of, was it economics or was it actual clinical judgment?
Oh, okay, yeah, good question. So the question is, the 3 scripts per capita, does it mean ones that are unwarranted or what? That they're just looking at raw number of population versus how many are bought, at the pharmacy, and that's kind of how our numbers come as well. So what that kind of means is, it depends on the country. But like in our country, for example, we're talking just scripts per capita. We're not talking all the over-the-counter products that are, ubiquitous around that our patients have access to, and the herbs and supplements. So my favorite definition is this, and I think if you always think about more medications that are clinically warranted, you already are way ahead in dealing with polypharmacy. And we'll talk about the systematic way to look at it. The first thing being, is there a diagnosis or a reason for taking this drug? You match up the problem list with the drugs, and there better be a reason for each one, or else you've got some polypharmacy going. Some people call it a random, uncontrolled experiment. My cynical self agrees with that, because we have so many evidence-based algorithms and data that have shown that if you use a certain cocktail of medications, it's very efficacious for managing various conditions. But if you look really hard at where we derive that data from, it's typically drug company sponsored, which means that the FDA only requires that they show more efficacy than the standard or equal, and not any significant harm. So we'll talk a little bit about how these studies are set up and brought to market, and how you should look at them, and how you should kind of analyze whether the way you're using the medications applies to the patient before you. And so the random uncontrolled experiment means if I've got 3 or 4 chronic conditions, hypertension, diabetes, COPD, there are algorithms and evidence-based recommendations of how to manage each of those problems, but there's like zero evidence of managing those problems together. There's zero guidance, and in that way it's kind of random. Polypharmacy, as I mentioned, is traditionally the realm of geriatrics, and it's considered a geriatric syndrome, and we'll talk about that in a second. The also thing to consider is there's different types of polypharmacy. I'll let you read that on your own. So you all probably know what a geriatric syndrome is by now, but just to review, they're problems that are highly prevalent and common to aging, especially in frail, multimorbid elders. Their impact on the quality of life and disability is substantial. They're not necessarily singular organic problems like rheumatoid arthritis or what have you. It's usually multifactorial, and one of those factors can be polypharmacy, a syndrome of harm. We actually have an interesting little exercise that I will share with you guys that you could use for teaching at some point, where take a look at this case here. So what we do is we assign learners different problems that are geriatric syndromes for them to work up and then come back and present. Anything ranging from dementia, dizziness, falls, incontinence, and polypharmacy. Those are all geriatric syndromes. But if you look at these syndromes and you look at the case, but if you look at the medications, you realize that each one of these syndromes could be caused by polypharmacy. And it's bidirectional. The syndromes can drive polypharmacy because people are trying to take medications trying to deal with the syndromes. So that's kind of just to point out, you know, how polypharmacy is considered a geriatric syndrome. When I use the word geriatric, I mean that you ought to think about also anybody who's frail and multimorbid, because what makes a geriatric patient susceptible to these syndromes is living with multiple diseases, living with maybe some cognitive and functional impairment, a lot of medications, and that could be anybody. It could be someone who had a spinal cord injury when they were 10 and they're very sarcopenic and they've got incontinence and a lot of other problems. They as well will have polypharmacy and other syndromes, much like an older person who has very little reserve. So in some ways, you guys are all pretty young, but when I was young, it kind of became evident to me that today what we see in terms of how we use medications is a side effect of modern medical system and modern medical practice. You know, back in the day, we all, like on the island where I'm from, we had one doctor, and that doctor knew everybody. Knew my family, knew my cousins, knew everybody. And if I came in and said, you know what, I'm not sleeping very well, that doctor knew that it was because my cousin just died of cancer, my whole family's traumatized, and they would have time, they would have an hour or so to coach you about it. Today, in the 15-minute office visit, if somebody comes in and says they're not sleeping, what can you offer them, right? Other than sleeping aids, which unfortunately can be just the symptom of depression or another problem. So in defense of physicians, because a lot of people, I don't know if you notice in the media, they're always like throwing darts at physicians going, you guys are prescribing so much because the pharma companies give you tips and money. Well, I wish that were true, but it's not. It's really the healthcare system. The healthcare system is only allowing you a short time with your patient, and in terms of what tools you have to offer to help problems, well, medications are up there at the top of the list. So why is this a problem? Well, adverse drug events are responsible for a lot of hospitalizations, and in hospital, over 2 million patients a year have an adverse drug event. The mean length of stay, cost, and mortality for adverse drug events patients are double that for those who are not in for adverse drug events, indicating that these are difficult problems to untangle. 106,000 are estimated to die every year from adverse drug events. And to put that in perspective, if you look at like the CDC cause of death numbers, basically heart disease is about 600,000 a year. cancer, 500,000, and then the rest of them drop down to about 155,000 for, lower respiratory disease, Alzheimer's, 110,000, diabetes, 79,000. So if you think about it, if medication-related problems were a disease, it would rank pretty high. It would rank about 4th or 5th in leading causes of death. The reason that it's not counted that way is something I haven't figured out yet. But just remember, adverse drug events are a leading cause of death. And now in this epidemic of controlled substance abuse, those accidental deaths have overtaken other causes such as car wrecks and other accidents. Adverse drug events rank as the 4th to 6th leading cause of death, and that would put it behind heart disease, cancer, and stroke, but ahead of diabetes. Again, looking at the healthcare system will pay for a 30-minute diabetic visit, but it won't pay for like 30 minutes of medication management. So that's part of what's driving this. It's not that, we're all out there trying to over-medicate everybody, but the healthcare system is driving a lot of polypharmacy. And just to give you an appreciation for how little we understand about the lovely pharmacology that you learned in school, now that I'm being made to teach pharmacology, it's clear to me that there's not enough time in med school or dental school to learn it all, and frankly, nobody likes it. And the reason is because it's a really complex subject. It's also a subject that changes a lot. So for example, when I was in school, we were taught that there were beta 1 and beta 2 receptors and drugs that worked on those receptors. Well, who knew there's beta 3s, right? Now, in the past 5 years, we've come to market a drug that's used for incontinence that works on the beta 3 system. So what I mean is, in my lifetime, the 50s, 60s, 90s, our knowledge of how drugs work is growing and the receptors they work on. So in some ways, we're using medications without fully understanding their effect on other parts of the body. One of the latest areas of study is basically looking at sarcopenia, or physiological changes that come with aging and illness. And you remember from kinetics, drugs compartmentalize and behave really differently in people who are not physiologically let's say the same as the people that the drug was tested on and brought to market. Basically, the drug was tested and brought to market on people like you, middle-aged, healthy adults. It wasn't tested on people who are sarcopenic and have little physiological reserve. And I think that's part of why we get in a lot of trouble with medications, is we end up using them in people who really can't tolerate the stress of using them. So this is just a little slide for you to look at, basically saying that this was in Nature, for every person that a medication is efficacious for, there's 3 to 24 people who are using it who it's not efficacious for. So that would be, how to manage polypharmacy. Rule number 1. Again, always ask if the drug is efficacious. So I have an interesting case coming in tomorrow. I have a polypharmacy clinic, referral clinic. No, do not send me all of your controlled substance problems, please. But I do have one coming in tomorrow who is definitely like a neurology case, definitely some psych and substance involved in there. But this person's 67-year-old's drug list is about 25 long. I'd say 10 of them are psychoactive. Several are opioid and pain management. 4 physicians, neurologists, primary, incontinence, so urologists, and psych. Well, I could pretty much figure out why she's got incontinence based on her meds, but the urinary, urologist is giving drugs that are actually making her psych problems worse. And this case is so complicated that my plan of attack is to sit her down and her husband, because pretty much her husband's running the show. She's not functional at a young age, and he's worried more about her polypharmacy. He's bringing her in, is to sit him down and say, do we have any idea what her baseline is off of all these medicines? Because if you look at her problem list, it's anxiety and depression. That's what it is. And she has a lot of other problems that clearly are medication-induced. So I'm going to start with this person and say, let's see if we could have a chance to see what do you think her baseline is. And I'm going to ask her, what do you think your baseline is? Do you think that you can live without all these? And we're going to talk a little bit later about deprescribing. I am not in favor of this movement to be a ballistic deprescriber. I think it has to be very thoughtful. But the way you start by approaching these massive drug lists is what's efficacious and what's not. We all know a lot of patients who are taking urinary incontinence meds who are still incontinent. So why expose yourself to those medicines if you're still incontinent? Okay, so here is a little sample study, drug study exclusion criteria that came across my desk several years ago. They were recruiting patients to test an Alzheimer's drug, and you couldn't participate in this study if you have a neurodegenerative disease or dementia other than Alzheimer's dementia. So do you see a problem with that? Most dementias are mixed. The second leading cause of dementia is vascular. And how do we know for sure that it's just Alzheimer's anyhow? Frequent smoker or consumer of caffeine, you can't participate in this study. So this drug will come to market, and then people will be using it with Mountain Dew and smoking all the time, right? And then hypothyroid folic acid, that makes sense. Presence of stroke or epilepsy or an MI in the past 5 years. Again, one of the other leading causes of dementia is vascular. So this drug will be used in probably a patient that does have these characteristics. And that's kind of why when drugs come to market, we get in trouble with them sometimes, because they're tested in a very particular selected group to show efficacy with very little adverse effects. So this drug actually did make it to market. And the dose had to be adjusted way, way down, because in this group of patients, it did great. It didn't do that great. If you look in the package insert, it separates from placebo like just barely, not even significant. But with the drug for Alzheimer's, people have nothing else to offer. So it became a popular drug, but the dose was way, way too high. Another thing to consider is that they don't test these drugs in people who have, as you can see, multi-morbid conditions, if they can avoid it. So always keep that in mind. This is what's driving our guidelines. That's how they do the major studies to say what's efficacious and what's not, and why, and what dose. So basically, we're trying drugs in this group, right? The gold standard is 2 equal groups, do an intervention, and then see what happens. And then we're using the drugs in this group, which is basically everybody over 50 years old, right? We all diverge physiologically from one another as we get older. So this is a really intuitive and obvious relationship that as you add numbers of drugs, you end up with a linear increase in the risk of adverse outcomes. And when that number hits 5, the risk of adverse outcomes becomes a little more exponential. And when it hits 9, it becomes really exponential. So that's where they get that literature definition, that 5 medications at the same time is polypharmacy. But also, when surveyors come to the hospital, they start looking for patients who are on 9 or more, and especially in the nursing home. And they'll hone in on those cases, and they'll look for medication errors and medication problems. That's based on this old data from the 1980s. But nonetheless, drug burden is important. So here's an interesting body of work done by a guy in Israel named Darren Garfinkel, and he does some deprescribing. But his deprescribing is not radical, actually. He took 2 sets of nursing home patients, and 240 in each group, one with usual care, one where they deprescribed 2.8 drugs per patient. And the drugs that they deprescribed were ones that absolutely they knew nobody needed, like the 3rd laxative on the order set, or nitrates in somebody who had no chest pain, had no real reason to use it, bedridden, etc. And what he found was the 1-year mortality rate was the normal, which is 45%. If you go to a nursing home, your average stay is about 2 years. Typically, you're there because you're going to die. So 45% in the usual care group and 21% in the study group. So if you can decrease 1-year mortality by taking a pill, you'd want that pill, right? So the pill is decreasing the amount of pills by not even the risky heavy-duty stuff, but just decreasing the burden. And that's where your over-the-counters and supplements are pretty dangerous. Because what in the analysis of this data, just by having that extra laxative order on the order set, increased the risk that somebody would have a drug interaction, for example. Like, for example, if you have somebody on acid suppression therapy and you give them a biscotal, oral tablet, that biscotal is designed to dissolve in the intestine where the pH is higher than the stomach. But if somebody's on acid suppression therapy, it's going to dissolve in the stomach. And it's going to cause cramps, pains, problems. Next thing you know, they're going to the hospital. So just by getting rid of the stuff that increases risk that you absolutely don't need, you decrease, according to Darren Garfinkel, mortality. I don't know about mortality, but we do know that we decrease hospitalizations and emergent situations. He also found that the annual referral rate to the ED for people from the nursing home was about 30%. And in the study group, it was about 12%. So that's pretty significant when you're trying to prevent readmissions. So that transition of care assessment is really important to get what all drugs the patient has in their house and try to minimize them. Physically get them away from the patient. So let's talk a little bit about drug burden. We were saying, in different countries it's different. Let's take a good look at United States. So I mentioned that in the United States, the average has always kind of hovered right here around 14, 16. Right now it's gone way up. 14, 15. And then right now it's gone way up to about 27 per capita. Obviously, that doesn't mean that everybody in this room is taking 27 medications, prescription medications. How they figure it out is they look at number of scripts that are adjudicated through insurance every month, and then they divide it by the number of people. So if my number's 1, at the end of a year, I'm 12. If you're taking 0, your number's 0, and then they just average it out. And so in our region, Kentucky, we've always sat at about 20, 22, and we always used to be able to make fun of West Virginia. They're valuable for that because they were always ahead of us. They always led the country in scripts per capita. It was always like West Virginia, Tennessee, Alabama, Kentucky. We were always in the top 4. But all of a sudden, we are way up there. We are now at 33 per capita. Mississippi is the highest at 35. And I think what has happened is the Affordable Care Act has, remember they ramped up the number of nurse practitioners and access points and insurance. And so that's, a good thing for access to care. And the quality measures we'll talk about later, that's another good thing because that should impart more rational medication management if we want good outcomes. But at this moment, I think what we're seeing is the effect of more access to care and more medications and, a lot of providers that are in different places, and it's harder to coordinate that care that way. Also, I just point out that the United States, embarrassingly, consumes 80% of the world's opioids and 99% of the hydrocodone. Enough about that. That's a different story. So our region has a problem, and I'm embarrassed because what I come here 10 years ago is to study it, and now it's getting worse. Obviously I'm not very effective, but it is kind of interesting that it's in our region. Here's that same data on a map, okay? And here's the parallel with BMI. So this is the 2009 BMI map, which was identical to the scripts per capita map. Now, the most updated BMI map actually changes the percent, so it doesn't look like our region is really as bad as it really is, but they've added another category here of people who are considered obese. And so Alabama, Mississippi, Louisiana being a higher percent of obesity, and us now with the new criteria, the old one only went up to 30, see? So that's why it looks a little different. But it's the same problem. And I've actually been in front of the Medicaid Cost Containment Committee a couple times in Frankfurt to say, hey, we have a really high scripts per capita, and if you guys want to invest in something that will help that, it would be really nice if you invest in healthy living. Take all that money, $400 a script for Abilify, take all that money and help people be healthy. Make sure that we have less food deserts. I lived downtown when I first moved here. Tell me how hard it was to go to the market. Well, you guys know, because probably a lot of you live around here because of your work. It's really hard to go to the grocery. It's really hard to find a place to go and exercise. You know, in Hawaii, I'd go for a walk every single day after work, in part because the weather's conducive. But we have to go out of our way here in our region because of the odd weather, unpredictable weather, to make sure that, you know, there's more healthy living. I think that would make a huge difference. Okay, so 1/3 of all your elders that are on hospital service, 1/3 of them are there because of medication-related misadventure. 1/3 of them. And I remember Dr. Setters, I guess a lot of you know Belinda Setters. She used to, we'd round with the residents, and she would say, "Okay, what's your differential for this patient?" And they'd say whatever, and she'd go, "Wrong, it's meds, it's meds, it's meds." And in some ways, you really have to scrutinize the meds in an older person who's living with polypharmacy. Another interesting statistic is that for every $1 Medicare spends on medications, it spends $1.33 addressing the problems caused by those medications. And actually, that's kind of an old statistic. I would imagine it's worse. But I don't know. I really just don't know how healthcare policy deciders can look at that and not want to work a little harder at polypharmacy. So what is it that leads, or what do we know in the literature about what leads to adverse drug events? So this is Jerry Gerwitz. He's up at UMass, and he does a lot of really interesting work in this area. He looked at people who were ambulatory, that means pretty with it, pretty healthy, living in the community, 65 to 80 years old, living with polypharmacy and having adverse events. And what he found was that adherence was only about 20% contributory to adverse events. Prescribing was like 60% contributory. And to me, this is fascinating, monitoring. So adherence, I'm going to tell you right now, we just invented that little pill that you can swallow and you can tell if somebody adheres. What do you guys think about that? I tell you what I think. I think you can't make somebody adhere. I think it's like a Fitbit. Okay, if you wear a Fitbit so that you'll exercise more, yeah, you might, depending on your motivation. But eventually, you're going to do what you're going to do. The biggest driver of adherence, from what I can see and from what I've read, is the belief that something works. And evidence would be, look at Ambien. If somebody runs out of an Ambien script, what happens? They're like pounding the doors to get the refill, right? But if somebody runs out of their statin, oh well, right? Because the Ambien you take and it gives you immediate feedback that it works. So typically psychoactive drugs are really easy to adhere to because you get feedback that they work. But if you're taking a maintenance drug and you don't have the health literacy coaching, you wouldn't know whether something's working to your benefit or making you better so that's the importance of us taking time to give feedback and teach people, you're taking this is how you monitor it, and this is the outcome we should find. So the low-hanging fruit, prescribing, we can't control that too well either. Because even if you're really excellent at prescribing your meds, you don't know for sure what the 5 other consultants are doing, necessarily. So prescribing is a tough one to actually control. Monitoring, we can control monitoring. Our healthcare system should and could be able to do better monitoring. And a lot of my research is about monitoring practices and pharmacovigilance. And there's a lot of gaps there, a lot. For example, I just looked at tamoxifen use. And some of the serious side effects of tamoxifen are thrombi, of course, and uterine malignancies. You really can't see those coming, but you can monitor whether the person's high risk. A lot of people had reasons for thrombi, like hypertension, history of cardiovascular disease, even a history of TIAs, and they were on tamoxifen, which is prothrombic, but they were not on any antithrombic agent. So those are simple things that we can actually do better pharmacovigilance and help this statistic get better. Okay, so here's more evidence that monitoring is important. This is a study of 100,000 people who are over the age of 65. And they were hospitalized for adverse drug events. And what it showed was that half of those people were over 80. So that kind of goes along with what we understand, that your ability to survive and endure intervention, whether it be surgery, medicine, whatever, medication, has to do with your physiological reserve. And people who are over 80, who are frail, they're going to have more side effects just because they're more vulnerable. 2/3 of those in the over 80 group were unintentional overdose, which might speak to impaired elimination or inappropriate dosing, overdosing. 4 medications were responsible for 67% of those cases of the over 80 people who were hospitalized. And the surprise was it wasn't the high-risk meds. The high-risk meds were only responsible for 1.2% of those hospitalizations. So the medications that were implicated included warfarin, the usual suspects, right? Warfarin, anticoagulants, insulin, oral hypoglycemics. These are ubiquitous medications. We know exactly how to monitor them, and apparently we're not doing a good job. These are not exotic drugs. So if we could do better monitoring, if we could get patients back in for follow-up, I know it's a healthcare system problem, but it would make a huge difference. I always try to encourage patients to self-monitor. I'm actually looking at an interesting little study that's part of a big NIH study, looking at specific medication literacy for each medication, like let's say a patient's taking. So we're looking at the asthma in the elderly database that we're working on right now, and we're asking patients, what is the purpose of this medication? What are the top side effects that you have to worry about? What are some drug interactions? What are some drug-disease interactions? And most people cannot name any side effects for any of their medicines. To me, that's rather shocking because every single medicine, no matter what it is, has at least one side effect. So if the person knew what to look out for, they could self-monitor a lot better. So these are some of the things that we could do better at. So how do you assess drug burden in your multi-morbid older patient? Well, I'm going to give you some of the principles to help you think about it. And in the next talk, we're going to talk about a system. So this is a big fad. You're going to see a lot of algorithms for deprescribing. And I do a lot of peer reviewing, and really, I'm pretty rough on these people because a lot of the providers that are writing these, like a lot of MPs and a lot of different people, or even pharmacists, they're saying, oh yeah, we can just deprescribe. It's really not that easy. Deprescribing is really not the goal. Appropriate prescribing is the goal. So basically, I think that some of these guys are zealots, and we don't want to be zealous about something that lowering drug burden just for the sake of lowering drug burden doesn't make sense. It has to be thoughtful. It has to be individualized. And that's the key. Good medication management is individualized medication management. So we have already talked along the lines of somebody's frail, they have less reserve, they're unable to endure problems like altered potassium levels or sodium levels due to psychotropic agents. It has to do with where you are on that frailty continuum. Also, age is not exactly an indication of frailty. We all know 60-year-olds who are really, really frail. We all know 80-year-olds who are climbing the Andes. So frailty is just a surrogate marker. And one of the problems, let's say in drug information, is it'll say, for patients over 65, you need to do X, Y, and Z. Well, that's not really exactly true. What they mean is, for the average patient who's 65 of a certain level of robustness, then these rules apply. Otherwise, you have to look at the person, and one of the things we look at a lot in geriatrics is walking speed. If somebody's not got good walking speed, I always tease the farm residents. I go, look, we can see renal failure walking down the hall. I always make them go get the patient in the waiting room and walk back. And if the patient's walking really slow and frail, I'll go, I think this one's about 32 mils per minute. And they go, oh, come on, you don't know. And then we'll sit down and calculate it, and it's pretty close. So you can see frailty and what frailty means in terms of how drugs behave just by looking at somebody's functional status. And you need to be cautious in people who are really frail. Harvey Cohen over at Duke, he had terms for categorizing levels of frailty. He called the young old, the old, and the very old. He called them the go-goes, the go-slows, or the slow-goes, and the no-goes. And so your go-goes and go-slows are people who are in excellent health. They live on their own. You know, they live in the community. Sometimes they're self-limiting because they're slowing down. They only drive down to the market and back. They don't drive on the freeway. Olds are typically people who are 75 to 85. They're slowing down. They live in assisted living. They take the van to Walmart as they're outing because they know better than to drive, and they get help with cooking. And then there's the no-goes. These are typically much, much older people who need full assist for activities of daily living. As far as polypharmacy is concerned, in this group here, the no-goes, polypharmacy does absolutely no good. And in fact, that's where deprescribing seems to make a really big difference, interestingly. Okay, the other thing that you want to think about, I wish I had thought of writing this grant. This guy, have you ever heard of the Inchianti study? This guy gets like a bazillion NIH dollars to go to Tuscany and study aging. And I'm thinking, well, how did they fund this? So he parks himself over in Tuscany, and he's studying things like surrogate markers of aging and then biomarkers, like walking speed, muscle strength, functional status. And this, a lot of spin-off papers. So here's one of them that looks at BMI versus creatinine clearance. And these are all ambulatory, community-dwelling adults with a normal serum creatinine, or serum creatinine of 1. And what he basically found, he stratified the categories by age and by BMI and by GFR. So the darker means lower GFR. And if you look at essentially all 85-year-olds are in the moderate to severe renal impairment range, all. So sometimes when I see 85-year-olds who are on aggressive doses of renally adjusted drugs, I think, well, how'd that happen? Sometimes it's because their serum creatinine looks normal. The other thing to consider is you have to look at their BMIs. So even though 100% of all 85-year-olds are in the severe to moderate renal impairment range and probably warrant some dose adjustment, when you get somebody whose BMI is more frail, you're going to have a higher percent that are in the severe range than somebody who's more robust. So again, age is a surrogate marker. Never trust the serum creatinine. If in all people who are 65 and over, bump it up to 1 in your calculation. And don't trust the eGFR readout, because the eGFR readout is more aggressive than what you need for renal dose adjustment. And we'll talk about that in a minute. The other kind of polypharmacy clinical pearl, we see this on geriatric hospital service all the time, like maybe once or twice a month. And it's called the triple whammy, which is acute renal failure induced by diuretics, nonsteroidals, and ACEs or ARBs used together in somebody who's frail. And here's the reason. Basically, you might have somebody who has poor cardiac output, lower blood volume due to diuretics. Prostaglandins are inhibited by nonsteroidals or aspirin, and they've got an ACE and an ARB. And those are the things that actually support glomerular blood flow. And if you're already kind of weak, you can kind of cut things off that way. Peel off these drugs, and the renal function tends to come back. Okay, let's see how we're doing on time. We're almost at 45 minutes. I'll give you guys a break in a minute. The second talk's a lot shorter. So one of the things that's important is being able to identify a drug side effect versus an organic problem. So I wanted to show you this little film clip that talks about akathisia with psychoactive medications and how it's very difficult to tell the difference.
It wasn't like a muscular thing, as though I had twitches or stiffness or anything like that. It's just that I couldn't feel comfortable. It was sort of...
Akathisia has two components to it. One is a subjective component of inner restlessness that often is in the large muscles in the legs.
I just couldn't sit still.
When it gets beyond the subjective component, then objectively it begins to look like fidgeting.
You know, and just had to keep moving around.
But at the upper end of the spectrum, people look extremely agitated.
I was just pacing around back and forth, and I didn't know how to help myself, and I was begging for help.
What was dramatic when I saw him was he couldn't sit. It was, an old-fashioned Akathisia description. He could not sit in my office. I used to walk with him on the corridor. So talk about privacy in hospitals and trying to get interviews. We're walking, getting history. I'm walking behind him.
It was like the energy in the muscle wanted to break out of my skin. And
by the time people are describing themselves as jumping out of their skin, that is highly suggestive of akathisia. But I think if you wait until the person tells you that they're jumping out of their skin, then you'll have missed a lot of akathisia, much of which is consequential below that level. It can be pretty disruptive below the jumping out of your skin level.
Okay, so I'm going to save us a little time. They're going to talk to a couple more patients, but you kind of get the idea. We're talking psychoactive medications that are used oftentimes for restlessness and anxiety and agitation, but also can cause that. And I had an interesting case about a month ago of a lady who was in the nursing home. She was taking Tramadol, she was taking aggressive doses of Prozac, and she was on an antipsychotic. And she ended up getting prescribed carbidopa-levodopa. So on one end of the spectrum, akathisia looks like agitation, but on the other end, it's really movement disorder. So we ended up taking away the Tramadol, which she probably shouldn't have had in the first place. That has serotonergic activity. We cut down her SSRI. And we removed was Abilify. And guess what? Tremor went away. And she didn't need her dopamine agent anymore. So it's really easy to misdiagnose drug side effects. And what are the signs of medication-related problems? In older people, in frail people, one of the number one signs is mental status change. Just like infection is, just like any other problem with an older and frail person. In particular, agitation, manic behavior, a change in mood or affect, and confusion. Sometimes not eating is a sign, sometimes not sleeping is a sign, and sometimes sleeping too much. So when I get these consults, the one thing I always want to document is any change in your mood, any change in your mental status, any change in your eating, sleeping, or are you sleepier? And then I try to look back and see, are any of the meds or recent additions causing this? And falls, of course. So what we're talking about here is the prescribing cascade, where you're given a drug. One of the most common prescribing cascades in older adults is the nonsteroidal use leading to hypertension or worsened hypertension and additional antihypertensive agents. Hydrochlorothiazide and gout, a lot of times people have patients with gout, and really the culprit is the diuretic. So remove the diuretic, the gout gets better. Also, anticholinergic use, right? High anticholinergic burden is really dangerous, makes people delirious. Here's work by Sarah Hilmer in Australia. She looked at number of anticholinergic agents and functional or cognitive status. And as you add number of agents, both domains take a hit. Sedative agents, not as much, but anticholinergic agents is a problem. So one thing we have to think about is that not every drug that we think of as being anticholinergic is the only anticholinergic out there. For example, furosemide has a pretty robust anticholinergic profile. So does olanzapine, which you might or might not think about. Diphenhydramine, atropine being, let's say, an anticholinergic equivalent of 1. So by the time you've got somebody with a bunch of maintenance medications and other anticholinergics, their level of cognitive impairment could be pretty significant. And you know that man who drove through like the farmer's market in Santa Monica several years ago? Maybe you guys are too young to remember that. And he killed like 15 people. The NTSB studied that case and expected to find that this guy was taking opioids, benzos. He was taking none. He was just frail. He had heart failure. He had almost 20 just maintenance medicines, and that was causing a lot of cognitive and physical impairment for him. Okay, so I'm going to skip this part about anticholinergics just to get closer to our break. The other thing you have to think about in terms of polypharmacy and things going wrong is, are your patients taking the pills as specified? So medications are designed like cars. There's specs and there's recs, right? The recs are what the drug company tells you. It's like, take this with food 1/2 hour before the same meal every day. There's a reason why they recommend that. But the specs are actually hidden in the prescribing information. Look under the pharmacokinetics. Look under the special situations. That tells you more about how the drug actually performs based on how it's designed. And, like your car, you're recommended to drive no more than like 110 miles an hour. But the truth is, it could go 160 if you really pushed it, right? The specs and the recs are different. Same thing with medications. So let's take tamsulosin, for example. If you take it 1/2 hour before the same meal every day, you're essentially saying take it with food. If you take this drug with food, tamsulosin also has a recommendation that if you don't get the effect you want after 2 weeks, double the dose. But if you look at the specs, turns out that the area under the curve, when taken on an empty stomach, can go up by up to 70%, and the peak can go up. So really, you shouldn't double the dose. You should have the person take it on an empty stomach and then see what happens. So the point is, a lot of times, the way a drug is recommended to be prescribed is kind of different than what the drug actually performs as based on the formulation, and you'll find that in the drug information. Also, in terms of polypharmacy, my generation's aging. And it's pretty embarrassing because the boomers like substances, and there's a lot of substance abuse coming down the pike with the aging boomers. I'm sure you've witnessed it already. Basically, in a nutshell, by 2020, approximately 50% of the persons 50 to 70 years old will be in the high risk for substance abuse group, versus 9% in the World War II generation. So that's something that, honestly, I don't think we in geriatrics have even really figured out how to deal with, because you can't detox these folks outpatient. They're too frail. We don't have enough facilities to detox. This is something we're working on. Okay, so where do you start? We're going to talk about that in the next talk. But there are some guidelines, and even though this applies to older adults, appropriateness of medication use applies to all people. So the Beers criteria and the start and stop criteria are good references. They're sorted out by system, like cardiovascular system, orthopedic system, etc. Also, make use of your point of care support. I'm sure you guys all use like Epocrates, Lexicomp, right? There's another one that Kornhauser has that I think is really handy that nobody seems to know is there. It's called Drug Facts and Comparisons. And Drug Facts and Comparisons let you search by indication. So if you ever wonder, what are all the drugs that you can use for a patient that has gout, renal failure, and liver failure? You can put in those things and it'll spit you out a list. And it's really kind of neat. So you go to Kornhauser, you go under, it's under F for Facts and Comparisons. And it will, oh great, I'm not logged in. Anyways, I'll let you guys do it at your convenience. But you can look out what can be appropriate for that specific patient by doing a search based that way. You're always welcome to call me, unless it's just an addiction case, okay? Also, there's a what drugs could you crush and what not to crush list that you can get at. What's crushable, what's not crushable. And also remember that some polypharmacy is intentional. I mentioned I'm from this part of the world. I'm from down there, that's off the map. But there's a place where in the old days they used to send people with Hansen's disease called Kalaupapa. And Kalaupapa is this funny little peninsula that sticks off of Molokai. And you can only get there by a scary little propeller plane, and you have to get permission. So I used to go there once a month to review the charts. There was only like 5 people still living there, and the Hawaiian government promised to take care of them until they died. And even though Hansen's disease there was a cure discovered, most of those folks do not want to move back into society because it's so disfiguring. So there's 5 people left, and they're lovely people. But I go in there, so here's how it looks. It's this peninsula that sticks out, and it's up against this wall of mountains. They really, really isolated people. And you get there, and there's nobody at the airport. They just drop you off and leave. And you better hope that the care home knows that you're there. And they forgot I was there, so I started walking. Well, it's like a mile and a half, no, more than that, 5 miles almost, of graves. It's just cemetery, 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 because everybody's died. You get to the care home, and this is the town. Only missionaries used to come and take care of the folks there, because nobody would come and take care of them. So it's an interesting little town. It's loaded with little churches, but it's like a ghost town. It's abandoned. And they get one physician once a month who comes in for half a day. And so I'm in there going, this guy shouldn't be on amiodarone. That's dangerous, right? I mean, nobody uses amiodarone unless you have to, especially long term. It's great at controlling heart rate. But long term, 45% of people have to get off of it because of side effects like pulmonary fibrosis and TSH problems. And so I happened to fly in with the doc that day, and I go, hey, get this guy off amiodarone. And he said, no. He said, there's nobody here to take care of him in case he gets another arrhythmia, and this is working. And I'm like, okay. So sometimes polypharmacy is intentional. All that stuff is important to document, and it's important to keep in mind that, inappropriate use sometimes happens on purpose.